Hey everyone, this is Mike. Welcome to another edition of Healthcare Update. The House has passed their version of the American Health Care Act, or the AHCA, and now the Senate is working on creating their own version. And it's not clear what they're coming up with. There's been a lot of other political controversies, and I've not really heard anything about what the Senate is thinking, except for a lot of interest in the so-called Collins-Sessions approach. Senator Susan Collins from Maine and Pete Sessions from Texas. Now, like the AHCA House version, they want to give some discretion to the states, but it's much less discretion. It's more discretion about how to structure the market for the individual insurance market and the exchanges. And states can choose to keep the ACA. They can, if they're on the federal exchange, they can stay with that, or they can create their own market-based alternative for the individual market. The structure of this will be founded on HSAs. Very similar in their approach to the Roth IRAs, where you deposit to the HSA with after-tax dollars if you're putting your own money in. But then any of your health spending, or if you accumulate some money and you invest it, those investment gains are not taxed. But the problem has always been with these health savings account approaches is that people don't save. Americans are terrible savers. They don't save for retirement, so they're certainly not saving for their health care needs. And so the Internal Revenue Service and state revenue services will be able to prime the pump. They'll be able to put tax credits, money directly taken off the citizen's tax bill. They can say, okay, you don't owe this much in taxes, but we're not going to give it back to you. We're going to put it in your health savings account, okay? So it's going to be a little complicated as far as how much do you put in. Now, they are going to get rid of the individual mandate, but this is the Pete Sessions approach. They're going to automatically enroll all citizens, or they're going to give states the right to automatically enroll all their citizens in a very basic high deductible plan. Now, in some of the proposals would give for their tax credits, the amount of the tax credit would equal the premiums for the high deductible plan. Other proposals that I've seen would not charge anything. There would be no premium, but they would offset the tax credit by an equivalent amount. So citizens will have the ability to opt out of this. But if they have a period of time where they don't have continuous coverage, they would be charged. Their premium when they do enroll would be 130%, which a lot of people argue is too low. And they would be able to perform some level of medical underwriting. They would be able to ask this person, you know, have you had cancer? Do you have cancer now? Does cancer run in your family, et cetera, et cetera. The advantage politically for the Republicans is it retains a lot of the popular provisions of the Affordable Care Act. So I've been kind of watching this, and you know, and James Capretta had a nice editorial in JAMA about this, and as I was reading to me, it kind of struck me something had been bothering me about our healthcare discourse. And do you remember back with the Affordable Care Act, we had a long period of discussion about what's wrong with our healthcare system. And we reached consensus on that. Now, we did not reach consensus on what to do about it, but we reached consensus on what the major problems in healthcare were. And the first thing was and this was from the right side of the political spectrum, the healthcare marketplace does not work because so many people are free riding. They don't have insurance and they just show up to the emergency room when they have a healthcare problem, and under federal law, the emergency rooms have to take care of them. That is a dysfunction. We're never going to get our healthcare marketplaces to work until we resolve that, which, you know, the political left said, okay, well, we're going to rename that as improving access. Everybody agreed that variations in the quality of care were a huge problem, and they also agreed that the cost of care was a huge problem. Okay, everybody agreed on that. Now, when you turn the conversation to what you can do about it, there was greater consensus, and that's why I have it in bigger font here, on improving access. There was some consensus on the quality of care, and there was no consensus about what to do about the cost of care. There was great debate, but no consensus. And so the Affordable Care Act, this is the balance in the Affordable Care Act. The vast majority of it is devoted to improving access. There are provisions in there, Act 2, Act 2, the second and third parts of the Affordable Care Act, Title 2 and Title 3, addressed quality of care and Medicaid, and there's a lot of quality issues in there. And then the cost of care, there's not a lot in there about the cost of care. Yeah, they provide subsidies to pay for out-of-pocket expenses, but to keep total health care spending down, the ACOs were about the limit of what I thought when I read the bill were the cost of care provisions, okay? So this is what bothers me about our current health care discussion. We're not reaching consensus on even what the problems are. Here's an example. You hear a lot of narrative about Medicaid is broken. Medicaid's not broken. Medicaid is expensive, but Medicaid is not broken. As you can see, Drew Altman from the Kaiser Family Foundation was talking about this recently, posted it online. There's a lot of satisfaction equivalent to with private health insurance. There's a lot of satisfaction with Medicaid and access. And now the cost to the states is expensive, yes, but to say Medicaid is broken is not true. So, we need to at least agree on what the problems are. Here's another issue that I thought was interesting. This month's Health Affairs has a article by Ming-Tai Seal about desktop medicine. And this was a study looking at primary care physicians, how they spend their time. And they did it in a kind of an interesting way. There's been studies like this which show primary care physicians spend a lot of time between patients just working at a desk, not talking to patients or interacting with patients at all. Well, what they did, Tai Seal and et al. Looked at the computer logon times. They used PCPs used one computer on their desktop and a different computer when they were seeing patients. So they were able to show that providers are spending 50% of their time on so-called desktop medicine. Is this really, they're paper pushers, right? Is this why these doctors went in? These are pretty, from a health system perspective, these are really expensive paper pushers. So is this really what we want them doing? And I would argue it's important we figure this out now because the trend is getting worse. Think about the future of wearable medicines when everybody has a device on them that is monitoring oxygen and glucose and blood pressure and all of these things, and all this information is flowing. If the typical physician has a panel of 2,500 patients and a few hundred of them are wearing these wearables, well, this is what they're going to look like. They're going to be just monitoring this constant inflow of data, and they're not going to be seeing patients at all. So this is an interesting discussion to start having now. What's the solution? Certainly team-based care, yes. But I think we also need to start thinking about how we recruit medical students and how we educate medical students, getting them ready for this future. So anyhow, that's some of the interesting things coming across my desk this week. I hope you have a great